Good morning all. Today's our topic is on apexification and apexogenesis. Coming to the apexification, it is a method of inducing apical closure by formation of a mineralized tissue in the apical region of a non-vital permanent tooth with an incompletely formed root apex. According to Cohen, it is defined as a method to induce development of the root apex of an immature pulpless tooth by the formation of osteocementum or bone-like tissue. It is indicated for the non-vital teeth with open apex. Why we are doing apexification? To induce either closure of open apical third of the root canal or the formation of an apical calcific barrier against which obturation can be achieved. We can use zinc oxide eugenol, resorbable tricalcium phosphate, collagen calcium phosphate gel, calcium hydroxide and MTA. According to Prine's criteria, first one is apex is closed through minimum recession of canal. Second, apex is closed with no changes in root space. Third, radiographically apparent calcific grit at the apex. Fourth one, there is no apical radiographic evidence of apical closure, but upon clinical instrumentation, there is definite stop at the apex. Coming to the procedure, in the first visit, pre-operative assessment include clinical evaluation of color, mobility, tenderness and swelling can be done. And then periapical radiograph should be evaluated. When acute signs and symptoms are absent, instrumentation is recommended. Application of the rubber dam following local anesthesia. Then access is gained in the pulp chamber. After that, Bart Bosch used to remove debris and necrotic pulp tissue from the canal. Irrigation is performed with saline. Work length is determined, circumferential enlargement done and irrigation is done with saline to remove infected dentine from the canal walls. Canal dried with paper points. Then calcium hydroxide powder is used to fill 2 mm short of the radiographic apex. Remaining of the canal filled with calcium hydroxide and saline. Barium sulfate added for radio opacity. Dry pledge of calcium hydroxide is then ejected into the pulp chamber and forced against the base ahead of it. Then place temporary restoration. In the second visit, this is done after 6 to 24 months. The tooth is re-entered and apexification is verified. If it is complete, then RCT is done. Comparative evaluation of apexification using MTA and calcium hydroxide. Coming to the MTA procedure, calcium hydroxide therapy was done. Then after 1 to 2 weeks of calcium hydroxide therapy, MTA powder is mixed with distilled water and carried into the canal with amalgam carrier. Tapped in place with paper point or plugger at apical 3 to 4 mm. Apical barrier formation verified with radiograph. Wet cotton placed over the chamber and excess cavity is sealed with reinforced zinc oxide eugenol. After 2 days, hardening of MTA checked. Remaining canal obturated with GP. Coming to the calcium hydroxide procedure, calcium hydroxide powder is used to fill 2 mm short of radiographic apex. Remaining canal is filled with the calcium hydroxide and saline. Then the barium sulfate is added for the radio opacity. A dry pledget of calcium hydroxide is then ejected into the pulp chamber and forced against the base ahead of it. Place temporary restoration. After 6 to 24 months, tooth is re-entered and apexification is verified. If complete, RCT was done. To follow-up visit, we can check for apical development monitored by comparison of pre-operative and post-operative radiograph. From that radiograph, we can check the formation of calcific bridge, continued apical development, absence of internal resorption, or periapical radiolucency. Coming to the apexogenesis, it is defined as the treatment of a vital pulp by capping or pulpotomy in order to permit continued growth of the root and closure of the open apex. Rationale for the apexogenesis was the maintenance of integrity of the radicular pulp tissue to allow for continued root growth. What are the indications for the apexogenesis? It is indicated for traumatized or pulpally involved vital permanent tooth when root apex is incompletely formed. There is no history of spontaneous pain, no sensitivity on percussion, no hemorrhage, normal radiographic appearance. Then what are the contraindications for the apexogenesis? Evidence that radicular pulp has undergone degenerative changes, purulent drainage, history of prolonged pain, necrotic debris in canal, and periapical radiolucency. Coming to the procedure. First, application of the rubber dam following the local anesthesia. Remove all the caries tooth structure and open up the pulp chamber. Remove the coronal pulp tissue with excavator. Care is taken to prevent damage to the radicular pulp. Rinse all the residual debris and control hemorrhage by placement of a moist cotton pallet over the amputated pulp. Calcium hydroxide mixture is placed over the pulp stems followed by temporary restoration. Follow-up radiographs are taken periodically to check the root development. Once the root development is complete, the conventional root canal treatment is done. This is a radiographic representation of the apexogenesis in picture A. It shows the traumatic injury to impermanent teeth, and the radiograph B showing that the calcium hydroxide apexogenesis was done. In C, it's continued root growth with the maintenance of vitality. Thank you.